Thank you for allowing me to present today. My name is Joseph DeVitis, and I'll be presenting the NOpioid protocol, which was implemented at Spectrum Health at Grand Rapids, Michigan. We have no disclosures. The United States faces an opioid epidemic, as we all know. 1.7 million patients carry a diagnosis of opioid misuse disorder, and 93,000 patients died of opioids just in 2020. The risk of abuse is evident in undergoing surgical procedures. For minor procedures, this confers a 5.9% chance of developing an opioid misuse disorder. And specifically, laparoscopic cholecystectomy has been identified as a procedure that places patients at risk. Depression, anxiety, and alcohol abuse also amplify these risk factors. For previous protocols that have been used to spare narcotics or limit narcotics have proven successful, such as the STOP trial, which demonstrated that only 9% of patients actually required a narcotic script after surgery for elective minor surgeries. And a recent article in the Journal of American College of Surgeons demonstrated that a narcotic-limited protocol using non-narcotic based meds plus a rescue script yielded satisfactory pain control, and most patients only required a single dose of oxycodone of 5 milligrams. We wanted to look at the acute setting, and so we conducted our study between October 2019 and October 2020. We had inclusion criteria with patients of age 18 to 65, no prior history of any chronic pain or chronic opioid use. They had to be able to take acetaminophen and ibuprofen without contraindication and have acceptable renal function. Surgical inclusion criteria included patients undergoing laparoscopic appendectomy for uncomplicated appendicitis and laparoscopic cholecystectomy for acute calculous cholecystitis. Bile spillage was not an exclusion criteria, and it was at the surgeon's discretion to place as many laparoscopic ports or fascial sutures. Patients were then discharged without a narcotic script. Instead, they were given scripts for 3 days of alternating Motrin and Tylenol. And counseling on pain control was done both preoperatively in the emergency department and at the time of discharge. Nursing and anesthesia providers were also thoroughly briefed on our protocol. There were no changes made to the inpatient pain protocols, and a handout was given to patients detailing how they should take their medications. If their pain control was ineffective, to call the clinic for a rescue script. They were then surveyed at their 2-week follow-up. In total, we collected 51 patients that met the inclusion criteria and completed the survey in its entirety. 32 were female, and just over half underwent laparoscopic appendectomy with an average age of 37.8 years. All of the patients surveyed rated their quality of life as either high or moderate or fair. No patients rated their quality of life as poor. Their average pain on postoperative day 3 was rated as a 4 out of 10, and a majority were either very satisfied or somewhat satisfied. Almost 80% of patients stopped taking their non-narcotic meds by postoperative day 6. There was no association with narcotic use or the need for narcotics with the presence of a fascial suture. There was no decreased pain control or issues with quality of life in patients that had pre-existing anxiety, depression, or alcohol use. There was no difference in quality of life or satisfaction between the appendectomy or cholecystectomy groups. Not everyone was satisfied. There were 3 patients that rated their pain control as somewhat dissatisfied, but on their 2-week follow-up did not indicate exactly why that was, and they felt that their pain control was adequate at that time. Another 3 patients were very dissatisfied, one of which did result in a rescue script. Another patient did go to the emergency department, but that was for a chief complaint of constipation and nausea, and they were discharged without a narcotic script from the emergency department. So our study really shows that patients can go home without a narcotic script after urgent laparoscopic appendectomy and cholecystectomy and achieve satisfactory pain control. While there's no one factor in the protocol that we identified as this is what makes it work, we do believe that the pre- and post-operative counseling on pain control and including all of our healthcare team members in the discussion to stay on message with patients. Our study is not without limitations. This is a single-center survey study. The way that we measure pain is subjective as it is. We did not use a validated score in terms of measuring quality of life. We simply asked, how is your quality of life? Our sample size was also a little bit too small. We expected a few more patients, but unfortunately we lost another 30 or 40 just from them not filling out the entire survey. There's obviously recall bias present, patients' willingness to fill out the survey, and the pandemic did affect this project in that patients did not return for their 2-week follow-up or call. Future studies would include expanding the operative criteria to either perforated appendicitis or other urgent laparoscopic procedures, or implementing a non-narcotic-based postoperative pain control protocol in the inpatient setting. In conclusion, surgeons play a critical role in reducing the exposure of narcotics to the patients. Our protocol has been implemented at Spectrum Health and continues to be used by the acute care surgeons based on the results of this study. Thank you.